Hi.
Hi, Fernando.
How are you?
Hi.
Hi, Robert. Good to see you. Good to see you, Fernando.
Good to see you all.
Hi, guys.
Yeah.
How are you?
Unfortunately, here in Brazil, things are not so good. At least are not good at all.
Oh, really?
Anyway.
But hopefully we'll improve, I believe. Mahmoud.
Hi.
Hi.
How are you?
I'm fine.
Lucas.
Thank you.
Good to see you.
Good to see you.
Yeah.
Hi,
I'm very well,
How are you?
Samad. How are you? Good to see you.
I was wondering how if you are going to join us, so it's okay. I think you just.
I was with Nasser until 5 minutes ago. I have to look after my other president as well, you know.
Yeah. You're right. You have a webinar this morning. Yes, I
just
saw
now they are still finishing.
Really.
Keki was talking on the other side. So,
Mahmoud, would you be so kind, please, to take a first moderation for the first part, taking care about necessity of Robert Spinner to give his presentation in
sure.
the first part of the webinar.
Okay, I will do that. I will try and open up the CVs because I don't have the two computers in front of me. I'm in a situation where I only have the phone. So I'll open up that one. And
I believe that it's now 4 o'clock exactly, so we can start officially.
Yes, we can start. We can start.
Okay, I think it's okay.
Some of you will do the introductions to start with.
Yes, yeah. Yes, I will do an introduction. I give for the Servade speech, and then you take care of the webinar.
Thank you.
Okay. So good morning, maybe, or good afternoon for the colleagues on the behalf of the Global Neurosurgery Committee and the Peripheral Neurosurgical Committee. It is with great pleasure that I welcome all of you in this joint webinar. It is organized by PNS committee and also by Global Neurosurgical Committee. And is coordinated by my colleague, Professor Luca Razulik, and myself, and Turkey, to the moderator who accepted to moderate this webinar, Professor Qureshi and Professor Razulik, Dr. David Edelson, coordinator of WFNS committee's activity, who supports this idea to prepare a joint webinar by WFNS committees. I would like also to recognize the effort of the Global Neurosurgery Secretariat team and Dr. Haku for this valuable assistance to make this webinar a success. The question first is why we have chosen this joint webinar. I will to go to share my screen.
Right.
Okay. Do you see my screen?
Yes, it's okay.
Do you see it?
Yes.
Okay.
Yes.
Okay. So this is the reason for organizing this webinar are numerous, and and the theme has been chosen: the centrality of peripheral neurosurgery. Why we have chosen this theme and this subspecialties? I think and we are confirmed that peripheral neurosurgery has been long considered as an essential neurosurgical subspecialty. However, its status within the global landscape has long been underappreciated and sometimes even neglected. However, unfortunately, there remains a dedicated group of peripheral neurosurgeons with the leadership of WFNS PNS committee who continue to promote this neurosurgical subspecialty. And we think that peripheral nerve surgery is central to global surgical provision and should be included as a priority in national public health planning. So the aim of this webinar is to discuss the current states of peripheral nerve surgery in the world with a focus on how to develop it in low and middle income countries. The second, to understand how forces can be joined to strengthen peripheral nerve surgery care in the world, and to share the Wfns-PNS committee view with Global Neurosurgery Committee and all neurosurgeons involved in global neurosurgery to promote peripheral nerve surgery. Global neurosurgery is a very important concept that has been developed the last 10 years. And we know that more than 23 million patients develop neurosurgical conditions worldwide each year. 5 million essential neurosurgical cases go untreated each year, mainly in low and middle income countries. Among them, there are thousands of peripheral nerve surgical diseases not being managed properly in low and middle income countries, and most of them comes at the stage of complication. WFNS leadership, WFNS committees, and other institutions have been involved actively in global neurosurgery activity to address the needs. And the Global Neurosurgery Committee, with the head of the other committees, aims to coordinate the efforts of global neurosurgeons in delivering safe, timely, and accessible neurosurgical care worldwide. The Global Neurosurgery Committee has many objectives that we share with other committees, of course, to achieve universal access to neurosurgical care, to align and coordinate all global neurosurgery activities within WFNS to reach the goal. Of course, it also promotes and stimulates research and co-advocate for investing in surgical care for all within universal health coverage. Global neurosurgery activity, and you can see here on these slides, and there are many interaction with all committees, and we think that we can develop more joint webinars, and this is the first edition of series of joint webinars that we start with the Peripheral Nerve Surgery Committee, and we think that the organization of other joint webinars are very important, since activities of Global Neurosurgical Committee are interconnected with all other WFNS committees activities. And this will enrich, for sure, the effort of all committees, namely to promote global neurosurgery. So this is just an introduction for this webinar with highlighting the importance of this joint committees activities to promote global neurosurgery in different subspecialties. Now, there is a welcome speech from Professor Servade, who was unfortunately unable to be with us. So he sent a message, just short message. Can you please, Dr. Haku?
Okay. Okay. Can you share your screen? Yes.
Yeah. Okay.
You see my screen?
Yeah.
Yeah.
Yes.
Dear colleagues, dear friends, my name is Franco Servade, and I am the president of the World Federation of Neurosurgical Society. I work here in Milano, in Humanitas University. The World Federation itself and the community of neurosurgeons is very happy to support the webinar that you will have today, which is a joint venture between the Global Neurosurgery Committee, led by Key Park and Professor Alawabi, and the Peripheral Nerve Section held by Professor Raslich. Peripheral nerve surgery is important for neurosurgeons, and this in many parts of the world neglected. We know that we have peripheral nerves damage from trauma, from tumors, from compression, and we need the neurosurgeons to be back in the field and to be prepared to deal with the peripheral nerve surgery. So I wish this meeting all the best success, and I want to see you all in person as soon as possible. All the best.
Okay, it's the welcome speech of
Professor Qureshi Mahmoud, can you go with the webinar, please?
Yes, thank you very much, Samad, for Professor Al-Wahabi. It's a pleasure to be a moderator for this very, very important subject. It is particularly important for us in Africa because, as all the participants who are from Africa will know, this is one area where we feel very, very, in a way, disabled. And we are really relying on the expertise of the panelists, such as Professor Lucas Rasulik, who has really moved the envelope as far as peripheral nerve surgery in a very big way. And indeed, it is my pleasure to introduce my co-moderator, who is now going to speak to us on peripheral nerve surgery, the bigger picture and its overview. Professor Lucas needs no introduction. He is really a giant as far as peripheral nerve surgery is concerned. And it is indeed because of him that the World Federation's committee in peripheral nerve surgery has made such big progress. Professor Lucas Rasulik, a pleasure to introduce you to our Continental Association of Africa, and a pleasure to have you give us your thoughts on the bigger picture overview. Thank you.
Thank you, Mahmoud. Thank you, Abdessamad. Thank you, Key, for this initiative, which have been accepted from on behalf of WFNS Committee for Peripheral Nerve Surgery. I'm sharing with you enthusiasm of members of the peripheral nerve surgery, not only those who are here today with us, but from all peripheral nerve surgery committee, from WFNS for this opportunity to present importance of peripheral nerve surgery. And yes, it is true, it is a part of neurosurgery. It is essential for neurosurgeons. It used to be neglected for some period, but so far we are all trying to increase the visibility and awareness about necessity for training and presenting the service of in peripheral neurosurgery worldwide. And this is not only my contribution, this is contribution of Mariano Sokolowski also, and all our members of WFNS committee who are here today with us, and all members who are watching us and doing their job every day, treating patients with peripheral nervous system diseases and injuries. My presentation is entitled Peripheral Nerve Surgery Big Picture Overview. Now I don't have anything to disclose. So cutting your nerve, change your brain. This is very true. We know all that. I believe that all of my colleagues, neurosurgeons who are working in WFNS Committee of Peripheral Nerve Surgery, sharing this feeling, which can be compared as a physical phenomenon entitled quantum entanglement, when a group of particles generated, interact, and share special proximity in a way such that the quantum state of each particle of the group cannot be described independently of the state of the others, including when the particles are separated by large distance. So this is something which we constantly, every day, trying to change. So cutting your nerve changes your brain. Peripheral neurosurgery within neurosurgery obviously is not Epstein-Podolsky-Rosen paradox. It is necessity for education for young neurosurgeons. It is also very important to be aware about the importance of multidisciplinarity and transdisciplinarity in peripheral neurosurgery, which is quantum entanglement. And finally, we are neurosurgeons. So in current evaluation of PubMed, around 67,550 articles about peripheral neurosurgery in human species only can be evaluated. Importance of international multicentric double-blind randomized cohort studies conditio sine qua non in our everyday job. So we have a lot of these possibility to see. It's still a matter of dilemma. Is it a class 1 evidence based on preoperative evaluation or coin flip based decision making as a matter of interoperative finding and surgical experience? And yes, Robert, thank you for this. Thank you for this discussion that we shared a long time ago. And this is also my opinion in my everyday practice. So this is very important for the low and middle income countries. Another very important issue for the peripheral neurosurgery is that we are waiting our results for some time. And this is the reason maybe why peripheral neurosurgery is not so attractive for the young neurosurgeons. But anyhow, this is famous photo from National Geographic about first cardio surgical intervention when a surgeon is waiting after 24-hour heart transplantation, waiting his patient vital signs. But comparing to us, we are waiting recovery of the patients for more than several months. So crisis versus opportunity, challenges versus opportunity. We choose to have an opportunity, to take an opportunity, to go into the challenge, which is nerve is regenerating, repair is possible, but why results are not better? This is courtesy of Professor Rajiv Mida, that we know that regeneration is slow, Stafford and hazard, and all nerve injuries are chronic, and reinnervation is very frequently misdirected, not specific and imprecise. But facing the challenges of peripheral neurosurgery in the 21st century and the peripheral neurosurgery avoiding the state of mind, the road less traveled, now leading us that we have a global neurosurgical workforce, mixed methods assessment of density of growth, 49,000 neurosurgeons in the world, with a learning curve and learning pyramid, which is very complex in general neurosurgery, as well in the peripheral neurosurgery with different educational methods. So in taking a discussion about big picture geographical specificities in countries such as UK, France, China, Korea, Japan, orthopedic surgeons and plastic surgeons are still working with peripheral neurosurgery cases. And in the United States, Germany, Spain, Italy, and other countries, a lot of Serbia, neurosurgeons are doing this. True meaning of the peripheral neurosurgery is it is interdisciplinary work. Of course, taking care about geographical specificities. Our mandatory activities is meticulous exam preoperatively by a surgeon and meticulous follow-up by a surgeon, which is a very important key point for a young generation. Then lesions in peripheral nerve surgery. No one is the same. They are very heterogeneous. And studying individual case, in some opinions, has more value than taking care about the cohort studies, which is not reflective of real world. It is well known as the Heisenberg effect. So in peripheral neurosurgery is really necessary and and tolerance towards diversity, ability to look things differently, exposure, surgery, which we have nerve injuries, which is also important to be aware about this fact, which can be important impact factor in recovery of the patient, especially in cases with nerve transfers. So these are some examples how it looks like when brain plasticity changes are evolving in the brain following intercostal nerve transfer in repair of elbow flexion. Also, in treating of phantom limb pain, there are some possibilities for this. We are now going to 21st century rapidly, fastly. This is one very nice book of my close friend Karl-Heinz Land about provoking the future, what will be in the future, and what is really going on every day, and seeking the perfection in our profession. This is something when we are facing now, man against machine, or machine against man, or machine is serving to the man, or man is not necessary, since machine is doing everything. This is not the situation in all countries all over the world. This is not the situation even in many countries in the middle income countries. This is a situation in countries which can afford this kind of possibility. What is a real life and real situation in peripheral nerve surgery is that is the peripheral nerve surgery as important as clipping an aneurysm, as resecting of brain tumor or spine stability? The answer is yes. So understanding the art in the skill and the skill in the art, completing from basic science to innovative activities, which must be involved in everyday practice in order to obtain our goal, which is best possible functional recovery and quality of life of our patients. So no master is born perfect. We have to devote our life to devote our time for training. We have to practice and practice and practice. This is very important for. This is example for vascular surgery, how it looks like when mentor and mentee are making a suture line. It is obvious difference. So how we will improve the big picture of peripheral neurosurgery. Frontal lessons with some hands-on cadaver lab simulation, etc. Using PowerPoint will lead us to the real boring situation. Interactive communication, like with faculty participants, discussion group, breakout session, hands-on courses are what we are doing every day. So Wfns Foundation, established by Professor Sami and directed by Professor Basso, and now from Professor Arez, is very important source for moving in the direction to educate people in the low and middle income countries how to work in the field of peripheral nerve surgery, of course, with the support of national societies. So Wfns Foundation Training Centers program consider postgraduate training centers, full program training centers, and short period training centers. This is something which really we are within the Wfns Committee of Peripheral Surgery trying to do our best in giving the possibility of young neurosurgeons to stay as a fellow in a fellowship program with the Centers of Excellence of Peripheral Neurosurgery. So full program training centers in Africa, as far as I know, is listed here. Many ideas appeared in the middle time, and this is something which we have to really take care about to develop strategy and tactics for developing peripheral neurosurgery in a low and middle income country. This is some example in some very low income countries in Africa, which perform the first brain surgery and let's say in standards which are, let's say, mandatory. So communication is very important, and neurosurgical community should be informed about neurosurgery, should be informed about peripheral neurosurgery. And on the other one side, we have a neurosurgical digital teaching, which is in low middle income countries beyond the frontiers of traditional education. A lot of possibilities you have here, like hybrid trainings, like education via websites, like via simulation, like role of mixed reality simulation for surgical training. Here example on spine, but in other surgical techniques. But the weakness of internet learning is no quality control in some sites, and every surgical approach can be posted even if it requires a long training curve, need for a place for where to display approved guidelines and procedures. So use of web technologies is telemedicine even by phone for consultation, novel guidelines for patient transfer, responsibility and control of the referral to neurosurgical centers. This is a classic. This is something which is now ongoing in many countries all over the world. Classical example of neurolysis. Direct suture. Nerve grafting. Interfascicular nerve grafting. Microscopic photos. Cable grafting of the nerve. Cable nerve, modified cable grafting. Some other nerve repair solutions, such as artificial repair solutions, which we are using in everyday practice. And of course, one example of nerve transfer as possibilities to help patients with brachial plexus injury. On the other hand, we have development of the robotic surgery and cadaver studies. So this is a cadaver trial from Brazilian group using the Da Vinci robot. They really presented a nice view on a cadaver trial to see all elements of the brachial plexus, even to perform nerve grafting. On the other hand, Brazilian group of surgeons used Da Vinci robot to perform some series of Oberlin procedure with the as robot. They report some nice results in 4 cases of Oberlin procedure and 6 patients with SOMSAC procedure. Artificial intelligence is nowadays conditio sine qua non, and we have to adapt on this, but we are coming back to the reality. Education and transdisciplinarity is used to be, and I believe it will be our reality for a long time. So there are a lot of examples of WFNS activities in which WFNS Committee of Peripheral Neurosurgery work as a joint. What we performed, thanks to the Mariano Sokolovsky initiative and all us, we support this project. It was a first online education project. I cannot say maybe in whole World Federation, but generally speaking, one of the first online projects in education in peripheral neurosurgery. This was, we have more than 400 registered neurosurgeons all around the world. And after that, they received this diploma. And this platform was based on Argentinian Association of Neurosurgeons. After that, we start theoretical and practical hands-on courses. World Federation started in 2016, and we have an excellent experience in León. Then second one was in Belgrade. Third one was in Frankfurt, in Germany. And fourth one was in Buenos Aires, Argentina. And then COVID-19 outbreak appears in 2020 and 2021. We were planning forthcoming course and already scheduled in Rio de Janeiro in Brazil, postponed of course, then following in Rovigo, Dubai. We hope that we will organize these courses also in Africa and of course in the United States. So what is our goal? Our goal is a functional recovery of the patient with a lesion of peripheral nerves, all kind of lesion. And this is something, this is the main activity which WFNS Committee for Peripheral Neurosurgery is working every day. So perspectives of nerve repair are also well known, and future development, we have to develop more efficient surgical techniques. We have to work on future development of application of suture techniques, pharmacological activation and stimulation of neuroregeneration, concept of cell neurosurgery, non-neural tubules, expansion of knowledge of neurotropism and neurotrophism. But for the hand of the surgeon will be, in my opinion, an irreplaceable factor, despite how the world would like in 21st century in all countries. Some of our publications of WFNS publications published in last years. So we also need to help our colleagues to publish journals. And in conclusions, hands-on courses, on-site training with the financial support of the Foundation of the Continental and National Society and on the basis activities should build up a bridge between countries, and especially countries with less resources. So keep calm and raise awareness and love brachial, plexus, and peripheral neurosurgery. This is our congress, which we like to, which we used to have last year in Belgrade, European Congress of Neurosurgery, biggest continental European neurosurgical event with a high impact of peripheral neurosurgery. But this will happen in October 2022, and I cordially invite you to join us in this congress. Thank you very much for your attention.
Thank you very much, Professor Lucas Vasilik. I think that's a huge challenge you've taken upon yourself to try and bring peripheral nerve surgery across the globe to the level that we wish it to be. But from your overview, it is quite evident that you are making every effort to try and get this very important agenda promoted across the world. And it obviously, from an African perspective, it is certainly a huge challenge, but we are heartened. We are deeply heartened and thankful that there is the WFNS and the WFNS Peripheral Nerve Surgery Committee that is making sure that we are not left behind. So thank you for that overview, and I'm sure there'll be lots of comments and commentaries about your talk. But I think we'll move on to our next speaker, and that is a young man from the Democratic Republic of Congo, DRC, who essentially this young gentleman has been trained in the Excellence Center in Rabat, and really he has taken the ethos of the Rabat Center in the sense that he wishes to ensure development not only in his country, but across parts of sub-Saharan Africa. And it's very pertinent that when we are having a talk or a discussion or a webinar on the situation in Africa, we have someone who is dedicated, keen, and interested in the development aspects of neurosurgery. And Jeff will give us, Dr. Jeff Natalja will give us the overview and possibly the flavor of what lies ahead in terms of how to address this challenge. So Jeff, Professor Jeff, Dr. Jeff Natalja, it's a pleasure to see you on this webinar. And please, I can see you have shared your screen, and please give us your talk. Thank you very much.
Thank you very much, Professor Kereshi. I'm happy to be with you in this webinar. I can say thank you for Committee of Global Neurosurgery to give me the opportunity to talk about Central Africa, the current situation of peripheral nerve surgery in Central Africa. So the problem of peripheral nerve surgery in Central Africa is like all of country in Africa is the big challenge, because we have a lot of problems for training, and the problem also of the neurosurgeon who doing this surgery. So for introduction, I can say that the peripheral nerve surgery can be traced back to the 17th century with Dr. Ferrara Sacher, when Dr. Ferrara Sacher a peripheral nerve in 1680. Disease enabled to peripheral nerve surgery caused an enormous social and economic burden worldwide problem. The regional prevalence of disease amenable to peripheral nerve surgery need to be quantified, like Professor Lucas said, for public health action to be taken. So in Central Africa, where there has been an increase in the rate of insurgents, high incidence of motor vehicle accidents, the exact incidence of peripheral nerve surgery has not been determined due to under-reporting and under-diagnosing. The paucity of information is very pronounced in the Democratic Republic of Congo, with our population about 18 million, where there has been an increase in traumatic injury due to the road traffic accident and conflict and non-communicable disease. You know that in Central Africa, we have around 8 countries. And in this country, these 8 countries, we have, I will show the table after, you will know the number of the neurosurgery. And there are some countries who didn't have neurosurgery today, like Central Africa and Sao Tome, we didn't have one neurosurgeon in this country. So, and the workforce density is about 0.22 neurosurgeons per 1 million inhabitants. Neurosurgical need is around 270,000 people in need in neurosurgical care each year. That is the table. I said that in Central Africa, we have some countries we didn't have neurosurgery, like Central Africa. They have no neurosurgery today, and Sao Tome, Principe, they didn't have neurosurgery. In my country, we have 1 neurosurgery for 70 million people. We have also the big problem for the number of neurosurgery. The most common cause of disease amenable to peripheral nerve surgery in Central Africa is traumatic, like many countries. And the tax shifting and sharing, orthopedic surgeons take care of disease because we didn't have many neurosurgeons who do it, of traumatic surgery, and general surgeon who do it. When you see this table, the service delivery, you can show that, we can see that in this 8 countries, the main peripheral nerve surgery we do is only Carpal Tunnel Syndrome. But the other one, we didn't have the training for example, the facial nerve. No one can do it today in South Africa, and foot drop, and even if tarsal tunnel, we didn't have many training for many neurosurgeons. The neurosurgeon who do it, they do this surgery in Central Africa. We need the training for that. The development of peripheral nerve in South Africa is hindered by a lack of data. In addition, most South African neurosurgeons have not received formal peripheral nerve surgery training. Only in Cameroon, we have 1 Cameroon neurosurgeon who received postgraduate peripheral nerve surgery training in Russia. So that he can do something, but is limited also. Also, the Central Africa neurosurgery that practice of peripheral nerve surgery lack the equipment, operative microscope, and microsurgery instruments to perform most peripheral nerve surgery intervention. And we have also the limited access to multidisciplinary team like the plastic neurosurgeon, surgeon, and physiatrist, and the physical therapist. For me, I think that when I understand Professor Lucas said that we need training opportunity for peripheral nerve surgery in Central Africa, with the collaboration with the high volume center who can go to do this training. We have also the problem of acquisition of microsurgical equipment, but we do some effort, but many countries didn't have it. And well, when I say that there are some countries in Central Africa today, we didn't have the neurosurgeon like Central African and South Sudan, who need also to have the training, not for the specialty of peripheral, but for the neurosurgery. They didn't have anyone neurosurgeon in this country. And we need also the support for research training, data collection, and the publication of studies. Thank you very much. Thank you.
Thank you, Jeff. Mahmoud, can you please invite Robert Spinner and then Eric Zager, since they are now sending me messages that they have to go to the OR.
I have just one comment. Okay.
Yes.
Well, Luca, I want just to make a comment very quickly before we go to the next speaker. First, I would like to congratulate you, but you are doing fantastic work for many, many years, and really, it's amazing. This is something that I want that you show that we know that, but for the young generation, they need to see that, and I want to ask you about the one question about the how to develop some education program, but you answer very well because many of our young neurosurgeons are seeking for that kind of education program, and you show us very, very many possibilities to go there. So thank you very much for that. For Jeff, thank you, Jeff, to see and to present this view. It's a very short view, but it's very interesting to know how the problems are. And for all the speakers who are outside Africa, they know now how the difference between what has been presented by Professor Luca Razulis about the development, the spectacular development on one side, and the needs in the other side. In some countries in Africa, mainly the sub-Sahara or state today, there are no neurosurgeons in some countries. So this is very important. This is really the goal of this joint webinar, to see how we can help in these countries. Thank you.
Thank you, Abdessamad. John, Jeff, for the beginning, I would like to invite you to join us to the Wfns committee. So please send me your email address and I will send you official invitation if you are, of course, willing to do this. And then we can start communicate and collaborate. Mahmoud, please.
Thank you.
Mahmoud. Oh, okay. Mahmoud Qureshi is here. Okay, I will continue with Mahmoud,
thank you.
Yes, please. Yes. Okay.
Yeah, thank you very much, Jeff, for representing Africa and giving us an overview of what the situation is in Africa. But I'm sure you'll take up the challenge as you've been asked by Lucas. Now, we've had a slight change in our schedule. Professor Robert Spinner has an urgent assignment to attend to, and we've had to bring his talk earlier. So Professor Robert Spinner is going to talk to us on evolving concepts in management of peripheral nerve tumors with reference to the brachial plexus. Please, Robert, go ahead. Thank you.
Thanks very much for having me. It's great to see some friends virtually. I look forward to going and joining colleagues in Serbia and other countries across the world. Today, really, I want to talk about tumors. I'm going to use the brachial plexus as an illustration, and I'm really going to focus in on the management and distinguishing benign versus malignant, how to manage syndromes, and when to operate on appropriate diagnoses. I think really the evaluation is based on imaging. The management then is the interpretation of the imaging, and several questions come up in questions such as when to biopsy, what the outcome should be, how much can you resect, what other treatments, and the role of reconstruction. Most of what I'm going to say relates to benign nerve sheath tumors, which we all see, and including the last speaker showing the management of schwannomas or neurofibromas. I think from the basics on, most patients present with symptoms without any deficits, and imaging shows a round tumor. The surgery is safe and should have excellent outcomes. My friend Ketan Desai has the largest experience, so it's nice to see him here. As an example, here's a median nerve tumor in the axilla, and you can see the target sign on T2. And here the resection can be done at a fascicular level, a stealth mission, the fascicles are displaced, and you resect the tumor safely. In the plexus itself, more proximally, the same demonstration could be shown here of an upper trunk schwannoma. Things get a little bit more complicated when we have dumbbell tumors, including the foraminal ones, and these can be taken out without any concerns, gross total resection without stabilization. The unusual tumors, however, are when patients present with large lesions like this, and then the neurosurgeon needs to be savvy with stabilization that would look like this. Now, this patient was sent to me. They thought that the woman had metastatic lesions, and in fact, this was my introduction to schwannomatosis, which is a benign condition, not very well known, but as common as Nf2. So I took out the lower trunk tumor, and it was a schwannoma. There was a small one in C6. And over the years, I've managed many of our other tumors, including sending one of the intracranial lesions to a colleague for Gamma Knife. We're all familiar with Nf2 with plexiform schwannomas, but most of the time these affect the acoustics. We don't really hear or see very much of the peripheral nerve lesions, but they're there for our management as well. We know from Ketan that the neurofibromas have slightly less favorable outcome, but still could be resected safely, and we know that from Dr. Klein's work. The most common syndrome is Nf1, and I think here, looking at patients, it's often difficult to know what's what. They need management, they need surveillance. Occasionally, you'll see large tumors like this, a dumbbell tumor crossing underneath the clavicle, and this actually was a pretty easy surgery. And you can see on T1 that the plexus was actually moved by it. But I think we're all familiar with the Nf1 plexiform lesions, which affect every nerve, and there's no surgery. Here is a good point of a patient who has lots of complaints and lots of tumors. In fact, his whole neck is a tumor, and you can't operate on that. Now, shifting over benign to malignant, the malignant nerve sheath tumor has three categories, either sporadic, the Nf1 related ones, or radiation. In contrast, I think the neurosurgeons need to know the basics, which is patients present with p-values showing that they have more pain, they typically have a deficit, and their tumors are not quite as round and quite as regular as the benign ones. So our role is a little bit different. Here we need to diagnose them, stage them, and get them the appropriate treatment, which involves other colleagues and other specifics, such as radiation or chemotherapy. And instead of an 80 or 90% success rate in maintaining function, now we're dealing with a 50% 5-year survival. Now, Fernando and some other colleagues on the phone today talk about whether or not you should biopsy. Now, for benign lesions like the routine schwannoma, we don't need to biopsy. In fact, it's wrong to biopsy. And for malignant ones, you should biopsy. I think the bigger question is the ones where you don't know but are worried. And I submit that people who are in the gray zone still should get a safe biopsy. So moving to Nf1 related MPNSTs, this mass isn't quite regular, and this patient presented with a quickly evolving deficit, but the patient didn't want a resection of any nerve. So I did a fascicular level negative margin resection here, and I have 15-year follow-up on this man. He was radiated afterward and did this well with this limited approach. On the other hand, with this patient with a different Nf1 malignancy, here's my biopsy tract, here's the PET scan. This was the resection with an amputation. I could have done something like this. This patient died from metastatic disease, despite the aggressive approach. So the jury's still out on the best treatment. Now, radiation-induced MPNSTs, here's my resection. But I want to just talk about something that Lucas talked about, which is now a reconstruction. This was the upper trunk. 2 days later, I went and did an Oberlins transfer. I see Samsak on the phone, so I also did his procedure. And here's my result, and she's very happy with elbow flexion. Now, there are other lesions that also could affect the brachial plexus, but they have a different pattern. So they present with neurologic deficit, they're benign, and the MRIs look different. We've all seen various cysts, most commonly in the perineal nerve, but they could be in the suprascapular nerve, and these arise from the shoulder joint, and you can do a limited operation. Stefano's on the phone, and he did lots of nice work on perineuromas. These patients present differently with an evolving lesion in young people, and they have a characteristic MRI that differs. Extraneural lesions can put pressure and compress nerves, and they can be taken out relatively easily, whether or not they're ganglion cysts from the joint. Here, I actually resected the suprascapular one. This isn't in the nerve, it's pushing the nerve, I took it out. Or a big lipoma that we recently did that you can see and it signals differently. Or a cystic hygroma that was pushing on the suprascapular nerve. And we're all confused about what to do with desmoids, including several people on the phone. And last, I just want to talk about other lesions that we'll see with neurologists. And there is a role for diagnosing neurologic entities in patients who are worsening and don't have a diagnosis. And here I take a fascicle based on MRI. This one led to the diagnosis of a perineurioma. With an MRI abnormality, I can take 1 or 2 fascicles and get a diagnosis with minimal complications. And we've diagnosed lots of things ranging from neurologically treatable ones to cancers in patients who didn't have a history of lymphoma or known treatment of breast cancer. I just want to end on what Lucas was revolving around, which is the future. Someday AI will figure all this out for us better than surgeons. Thanks very much.
Thank you, Robert, for this outstanding lecture. And we can have some comments now, since I believe that Dr. Spinner will have to leave in a short time. So any comments, questions?
I don't see any.
Robert, can I ask one question?
Yes.
Yeah, Robert Ketan here. What is your take on biopsy of the tumors? Which patients you will do biopsy?
So I biopsy the ones that I'm worried about. So these are, Ketan, you're on mute, but I understand your question. So for ones who have a few symptoms, who have a round mass, have a normal exam, I wouldn't biopsy. The ones that are growing fast, or the ones that I'm concerned are malignant or have irregular features where the radiologist with experience is not confident, then percutaneously I can do safe biopsies. But it's only the ones that I'm worried about.
You know why I was asking this question was that recently we have done a prospective study of the last 3 years, and we have studied about 42 patients of nerve tumors. And what we have seen is that those patients who have malignant tumors, their clinical criteria or the clinical presentation is entirely different than the benign ones. The patients with malignant tumors have very rapid progression of symptoms. Their neurological deficits are very severe, and over a period of time, they have very severe deficit. And the duration of symptoms is very short. That is what we have observed in cases where patients have malignant tumor. And on that basis, prospectively, we have biopsied those tumors. And those patients who have a slow progressive symptoms and very minimal deficit, we haven't done biopsy. And we have confirmed it intraoperatively by frozen section. And to be very honest, we haven't found any difficulty. Only one case, which was biopsy proven neurofibroma, but the clinical symptoms were very rapid, and eventually it turned out to be a malignant one. So I think clinical criteria are very, very important in deciding whether the patient should undergo a biopsy or not. And I think that may, to some extent, solve the issue of whether to biopsy or not, because there are proponents and opponents related to the biopsy procedure prior to surgery.
Well, I agree with everything you said. The real reason for some of the learners is that I don't want treated preoperatively with some other management. So first of all, you would counsel the patient different. You would do a different operation. And then if you go back in, then you have to worry about tumor seeding and all the other things. So having a diagnosis, just like with stereotactic neurosurgery, is part of what we do. So I never really understand the controversy in biopsying a malignant lesion because it does change your management. And here, at least at Mayo, we do preoperative radiation to try to shrink the tumor down, which of course you wouldn't do with benign lesions. It's a gray zone. I know Eric is on, Fernando, everyone has opinions. I think my opinion is probably very close to what you're saying with prospective data. So thank you.
Yes, thanks.
And may I have a question, please?
Yes, please go ahead.
Yeah. Thank you, Professor Spinner, for your excellent presentation. I have just a question. Is the presence of recurring Gaussian neurofibromatosis of recurring Gaussian make you change your surgical policy in case of brachial tumors?
Of of neurofibromas?
Yes. In case of association, yes.
Well, it depends. If it's with Nf1, then I would only take out a symptomatic lesion or one that's growing. I still think they can be done safely in the right circumstance, and I don't take out every tumor. So I think the points that Ketan has made are valid. We still go for ones that are causing symptoms. If I'm worried about them because they're growing fast, then I'm worried about a malignancy. And then I would have biopsied, staged, and treated differently if we found something unexpected.
Are there any other comments or questions?
I believe that we should move on since we are to follow our time.
Sure. I believe that we now have next Mariano Sokolovsky. Are we ready to talk to us about differences in brachial plexus between Germany and Argentina?
Yes,
Mariano?
I'm here. Do you hear
okay,
me?
would you like to?
Okay.
Yeah, great, super.
Yes.
Next speaker will be Eric Zager.
Oh.
But Mariano's next, right?
Mariano, after you.
Okay. I will leave the image. Okay. Just a second.
No, Mariano, you should, okay, it doesn't matter. You can do it, and then Eric, and then or Eric after you. So this is
Then I go. Okay. No worries.
Okay, Mariano.
Yes. Can you see me?
I can see you. I have an OR waiting for me. Would you mind if I went first?
Oh no, please.
Oh, thank you so much. I apologize. I only asked because you're my good friend.
I was just following orders.
Mariano, he's actually going to play golf today.
I wish. The OR may call me in the middle of this talk, but they're waiting for me. Thank you, Mariano. I appreciate it. I owe you one.
Lucas, go ahead and introduce next speaker, please.
My pleasure to introduce Dr. Eric Zager, who is a big name in peripheral nerve surgery within neurosurgery. From his graduation in Stanford University, and then internship in Columbia University, then in Massachusetts General Hospital in Boston. Also, a lot of fellowship and internship in activities in United States and worldwide. One of the most prominent peripheral nerve surgeon in the world. And I mean, I can speak next 2 hours about Eric Zager, but I think he's now in a rush for his OR. So Eric, thank you very much for joining us. And this is we are always doing, respecting all of us between us, please.
Thank you very much, Lucas, for inviting me and for that kind introduction. Thank you, Mariano, for allowing me to step in front. I'll pay you back later. It's always difficult to follow Dr. Spinner with any type of talk. That was wonderful. Do you have my slides, or do I share the screen?
Oh, no, you share the screen,
okay.
Please.
Do you see that now?
Yeah.
Okay, so, all right.
Just start your presentation.
Yes. So what I want to talk about very briefly is just the simplicity of neurosurgery and of peripheral nerve surgery in particular. And we're talking today with low and middle income countries and how we can translate our knowledge of nerve surgery to this specific forum. And the point of my talk is really that nerve surgery can be quite simple, and the essence of it is to think in simple terms. We don't need high technology for peripheral nerve surgery. We're dealing mainly with trauma, but also entrapments and tumors, as Dr. Spinner showed us. And if we think simply and try not to complicate our lives, this can be done in low and middle income countries with good competence and education. So very simply, I'm going to talk about the fact that your clinical history and exam are the foundations of diagnosis in peripheral nerve surgery. So we don't need fancy MRIs and MR neurography and so forth and robots to do peripheral nerve surgery. If you talk about the indications for surgery, they should be conservative measures first, and the indications are simply failure of conservative management for most lesions. The surgical technique itself should be simple in order to avoid complications. The more complex a procedure is, the higher the risk of complications. That's been shown over and over again. And you can do nerve surgery with basic instruments. Again, you don't need really high-tech, fancy navigation and so forth. It can be done with basic general surgery instruments. And finally, if you have a complication, as in any type of surgery, you must face it, accept it, and deal with it in a timely fashion. So I'll draw simple examples from these 4 areas: ulnar neuropathy at the elbow, carpal tunnel syndrome, which we all see are very common, nerve tumors, and nerve trauma. So for the ulnar nerve at the elbow, the anatomy sometimes looks somewhat complex, but you can break it down into simple terms of where the nerve is going to be focally compressed, which you can identify with tapping over the nerve and with either a simple low-cost ultrasound or a low-cost electrodiagnostic study. And so what's wrong with this incision if you're looking to decompress the ulnar nerve? First of all, if this is the olecranon here, the nerve doesn't run midway between these 2 bony prominences. It hugs the epicondyle. You can reach it with this incision. In fact, you can reach it with this incision, but this upper incision that's dotted is more likely to injure some cutaneous nerves and cause a pain syndrome. So you can make a short incision, shorter than this, 3 or 4 centimeters is enough, decompress the nerve as it hugs the medial epicondyle, and you don't have to do any bone decompression. You don't have to do a transposition in most cases, and you can do a simple surgery and get good results. If you're doing a transposition, this incision is too short, in my opinion, because you're going to end up kinking the nerve either proximally or distally once you transpose it. So you have to know the simple basics of what procedure you're trying to do and what approach will get you there best. If you create a new nerve injury, you're not going to have a happy patient. This is an ulnar nerve, but this is a very large cutaneous branch crossing the ulnar nerve. It's almost the size of the ulnar nerve in this example. That's not common, but the point is protect the cutaneous nerves during your exposure. Don't just use monopolar cautery or Bovie to go through the subcutaneous tissues. You'll injure these cutaneous nerves and cause a pain syndrome. You're trying to help the ulnar nerve, but you're not trying to create new nerve injuries. So expose and protect your cutaneous nerves during any operative approach. And how do you decide whether to do a transposition or a simple decompression? I think we all know now, after several studies that have been done over 10, 15 years ago that were randomized trials showing that simple decompression results are as good as transposition in most cases. And there are fewer complications. So again, keep it simple. A simple decompression under local anesthesia gets you very good results. And in most cases, you don't have to do a transposition. When do I do a transposition? Well, I have my own indications for that. If a patient has already had a failed decompression or a subcutaneous transposition, then I'll do a submuscular transposition. If there's spontaneous symptomatic nerve subluxation or dislocation across the medial epicondyle, then I will recommend a transposition. And if you have an elbow deformity that looks like this from a prior fracture dislocation, then you need to move that nerve away from this fracture callus and deformity in order to get a good result. So that's my list of how to decide when to do a transposition. I guess I would add to that, if you're also needing to do a nerve repair in the case of a nerve transection, then a transposition will gain you length, and you'll either be able to do a primary end-to-end repair or a shorter nerve graft. What's wrong with this incision in carpal tunnel syndrome? Well, in my experience, that incision is unnecessarily long. You're more likely to injure the vascular arcade or the recurrent nerve with that long curved incision. You don't generally have to cross the wrist crease. You are avoiding the palmar median branch, but if you go too far toward the ulnar side, you can injure the ulnar cutaneous or even the ulnar nerve and artery. I think you can modify your incision. You can do a shorter incision. You don't want to screw up a simple operation by injuring ulnar nerve, by injuring distal branches or vascular arcade. So again, a careful study with basic instruments can be done for this disorder. This is my usual procedure now, is a mini open carpal tunnel. You can do it endoscopically, but that's more expensive. So we're talking about low and middle income countries. A simple open procedure works very well, has the same long-term results as endoscopic. And as long as you fully decompress, then you don't end up with this type of scenario where a surgeon is inexperienced with endoscopy and ends up slicing the median nerve with one of his first endoscopic procedures. So this needed a sural nerve cable graft repair, and you can get good results, but that's not what you want to see in your first endoscopic surgery. So things not to do with carpal tunnel: keep it simple. You don't need to do internal neurolysis in most cases. You don't need to do routine rotational grafts. And please don't do just a weekend endoscopic course and start doing these procedures without a mentor. What about tumors? Well, Rob covered it very nicely. Just for general management, if you tap on a lump and you get a Tenel's sign extending down to the hand or the foot, that probably will tell you what nerve is involved. And you don't necessarily need a fancy MRI. I'm a big fan of imaging. We use it all the time. But in a low or middle income country, you could do a cheaper ultrasound You could even explore some of these that look obvious to involve nerve without imaging. That's not my standard of care, but I'm talking about for low and middle income countries, it can be done. As Rob mentioned, we don't biopsy routinely unless there's a high suspicion for malignancy. Always ask about a family history, look for the skin signs of neurofibromatosis. I always get the imaging studies, but again, we talked about the limitations with cost. And many tumors that grow slowly and are minimally symptomatic and small can simply be followed conservatively. You don't have to operate on every lump and should not operate on every nerve tumor just because it's there, only if it's growing and symptomatic. In terms of the resection itself, always with a benign tumor, your goal is to preserve the nerve. As Steve Russell told us years ago with a beautiful article with David Klein, preserve the nerve is the goal. And that means finding the correct plane of dissection beneath the pseudocapsule. You're peeling the onion and keep peeling until you're essentially almost in the tumor itself. Very different technique for a malignancy. I'm talking about a benign nerve sheath tumor. And of course, a cheap throwaway stimulator, nerve stimulator, helps you identify the functioning motor fascicles. So that can be done in low and middle income countries quite cheaply. And finally, in terms of nerve trauma, the basic precepts are identify the mechanism of injury, understand whether it's an open or a closed injury, because those are generally managed differently. You must document serial neurologic exams carefully. You must think about the timing of your electrodiagnostic studies, which tell you whether you have to operate or not, and also when to operate. And basically, for failure of nerve regeneration, that's when we're operating on closed injuries. For open, sharp injuries, we're operating acutely. Because the nerves run with the blood vessels. So you have to anticipate in trauma that there may be some vascular injury. If you can, get imaging studies to document the vascular anatomy. But of course, examine the patient for pulses and hematomas. And finally, very importantly, and often overlooked and neglected, is manage the pain of nerve trauma, because that's usually the patient's major complaint, with whether it's brachial plexus or peripheral extremity injuries. Pain is what the patient cares about, and you have to manage that in an appropriate multidisciplinary fashion. So consult your pain management people, your anesthesiologists, your physiatrists, etc. So I will stop there. Thank you very much again for inviting me. Thank you, Mariano, for allowing me to go first. And I do have to go to the operating room, and I will look forward to seeing all of you in person, hopefully soon in the next year. I'm happy to answer questions.
Thank you very much. Thank you, Eric. Any questions to Eric before he has to leave?
I have some questions.
Introduce yourself and.
Okay, my name is Hisham Subki from Egypt. I have a question about the peripheral nerve tumor. When we make surgery on the benign peripheral nerve tumors, there are some pseudocapsule. In this pseudocapsule, sometimes there is some tiny branches. So we should excise this capsule totally, or we can suture it after removing the tumor.
That's a good question. If I see a fascicle, if I can preserve it, I will preserve it. I go to great lengths to preserve every visible fascicle for a benign nerve sheath tumor. There are some cases, and in fact, many cases, in which you will see one or two small fascicles that directly enter the tumor, and it's clear that that is the fascicle of origin of that tumor. And you must sacrifice that fascicle in order to do a complete resection. So I'll always stimulate to make sure it's not a major motor branch. Usually these are sensory. Usually there's some sensory redundancy, so you can take those fascicles without a major sensory loss. But my major goal is to preserve every viable fascicle. And eventually you'll get down to the fascicle that is the fascicle of origin of that tumor. And that fascicle cannot be saved if you're going to do a gross total resection. So in general, save everything that looks like it's savable. I hope that answers your question.
My question is about the...
Go ahead.
My question is about the pseudo can be removed or not?
I'm sorry, I missed that. The capsule, should that be removed?
Yes, the pseudo capsule of the tumor should be removed totally or not?
It does not have to be removed. And in my experience, the tumor has a very low risk of recurrence despite leaving the pseudo capsule. Again, the pseudo capsule, as you mentioned, may contain some functional fascicles. So anything that looks functional or responds to stimulation, I will try to preserve.
Thank you. Thank you.
Luca, may I make a comment, please? Luca, I want just a comment for,
yes.
for Dr. Zager. Thank you very much. Thank you very much. The way you present this peripheral neurosurgery, making it simple. It's exactly meet what the expectation of most of young neurosurgeons, especially in low and middle income country. And I'm very happy that you insist at the beginning on the clinical examination. It's very important. And then EMG and the other exploration. But still, the way you present it, I think it breaks the myth that it's something that's complicated. And it's very, very important for young neurosurgeon to start with simple case as you presented. Of course, there are many difficult cases, but they can start by the simple case and they get confidence, and then they can get some scholarships in their department or other department with big cases, and they learn in the future. Thank you very much.
Thank you.
Thank you, Eric, again. And I think we're ready to take Mariano's lecture. Mariano?
Yes, here.
Yeah, please go ahead. Thank you. Differences in between Germany and Argentina. And we're not talking about football. And we're not talking about football.
No, just in BPI. No soccer this time. Well, thank you. Thanks for the moderators and to the coordinators of this very interesting meeting, and especially thanks to Chef for his wonderful talk. So, Lucas, we should note this important report that happens in Central Africa, right? And start working on that. Also, Lucas, thanks for mentioning my name during your talk, as it is not fair because we are a big team working all together since at this time many years, trying to spread out peripheral nerve surgery all around the world. So what I'm gonna speak about is differences in BPI, not in soccer, between Germany and Argentina. I used to call this talk Geography, a Forgotten Factor. So when I started to get interested in peripheral nerve surgery and brachial plexus during my residency program, I used to read a lot of articles and about this subject, and I always saw the same thing. The most common BPI injury was upper type, C5, C6. But after starting doing my own practice, I thought that this might not be true, at least in our country, because we saw a lot of complete injuries instead of upper type, C5, C6. So I think in BPI surgery, there are lots of interesting papers, of course, but we should ask ourselves before applying any technique that we learn from a paper or from a weekend course like Eric talked about, we should notice where do they come from? Because sometimes we might be comparing apples and pears. So in this joint global and peripheral nerve meeting, I think it's important to speak about some of these social differences we can see. For example, let's take just an example, Myanmar, which is a country you all know, near India, China, and Thailand. So they have a very specific way of driving. They have the steering wheel on the right, like in UK, in England, and in other countries. But the sense of the direction in which they drive is like in USA, Argentina, or many other countries. So this makes a very dangerous way of driving, because if you want to take over this white car that you see, you have to show all the left half of your car before knowing what's going on the other side, right? This is very dangerous. And as a result, of course, there are a lot of accidents there in Myanmar. So please take care about the geography, because the social environment of your work and also of certain papers and courses. We have this German South American meeting. The third one was organized very nicely by Nora Dengler in Berlin, just before the pandemic attack. So we really missed this kind of meeting. But in that meeting, we started to get the idea of comparing what's going on in two countries. Let's take as an example a very highly industrialized European country as Germany in comparison with a big middle income Latin America country like mine, Argentina. So the Germans are almost double than the Argentinians, but the most important difference is that GDP per capita is almost 3 times in Germany comparing to what's going on in Argentina. The life expectancy is not very different. So we took patients from Gregor Antoniadis' group from Germany and our group in Argentina, and we saw very different things. For example, Germans were older in general, were taller, and were heavier, all significant than their Argentinian counterparts. So in the left, you can see a typical German motorcycle driver who used perhaps his motorcycle for recreation or for going once every while to his work. But in Argentina, there's a lot of young people who are, as I said, thin and are smaller, and they have smaller motorcycles, and they use them all the time for work, for going from one side to the other. They use as the unique way of transport. So as a result, the Germans, because they have different type of body in comparison of, I'm speaking just about BPI injuries, right? This is okay, here we go. Can you hear me now?
Yes, yes.
Yes, okay. So the Germans have a 7.5 less severe lesions than the Argentinians. So the Argentinians have more complete brachial plexus injuries. This is very important. And 50% of our patients were not using helmets. Of our BPI patients were not using helmets at the time of the accident. And of course, this means that more severe trauma was present in them. So another difference we saw is that Germans are more likely to have struck another vehicle in movement, right? But the Argentinians, they usually hit a vertical stationary object like a tree, pole, or wall, or whatever. And this has, of course, legal implications, and it is not always easy to get this information. Many of them were using alcohol or drugs when they drove their motorcycle and they had the accident. So this kind of social difference and social environments should be considered by us. So what I'm speaking about was published in this journal, Journal of Brachial Plexus Peripheral Nerve Injury in 2019. If someone wants to see this, this information is written. And as I said, just to finish, maybe we are comparing apples and pears. So take care about this type of social differences. Thanks for your attention.
Mahmoud, would you continue? Or I will thank you, Mariano, for this excellent presentation. And
thank you, Lucas.
Focusing.
Is there any big question?
Yes, focusing on the also important factors which we have to take care and to have in mind when we are dealing with the patient with peripheral nerve injuries. Any questions, comments?
Can I?
Yes.
Yeah, thanks, Lucas. Hi, Mariano.
How are you?
Yeah, what you said, I totally agree with you. And same situation, what you said is also there in our country. In fact, just to add to your point, since a lot of people don't wear helmets, their injuries are more severe, and the patient's treatment is more focused on the other injuries. And in that respect, the brachial plexus injury is relegated and they come late, they present late to us. And in fact, the complete palsies are more common to us. In fact, if the patient comes with a partial palsy, it is a luxury. Majority of patients have complete palsy. So I completely agree with what you said. Thanks.
Thank you. Thank you very much. Thank you very much for your time.
Any other question, comments?
Okay. All right. Sounds like we are ready to go on to Stefano's talk. Is that right, Stefano?
Yeah.
Okay. Would you like to share your screen?
Yeah.
Stefano is a board certified in neurosurgery from the University of Milan, and he's also board certified in neuropathology, and is currently you based in Milan. Is that right? And he speaks.
Yes.
He speaks more languages than every one of us on the webinar put together. He's Italian, fluent in everything. The only one I noticed is not is Swahili, which is in Africa, but that's fine. You will learn when you start coming to Africa to help us develop peripheral nerve surgery, Stefano.
Thank you very much. Yes. So I want to talk. Can you see my screen? Are you okay?
Yes, we can see your screen.
Can you? Okay, fine. So I've chosen this issue because it is quite rare and there are much debate, and many people probably have this syndrome, which is underestimated, also because many of us don't know how to treat it. The symptoms, of course, it is a headache, but it is a very particular headache in the base of the neck, in the occipital area, sometimes behind the eyes. And also the patients develop I should say, a psychological syndrome, because they are fed up with doctors who are not able to understand what they have. They defy a diagnosis of a typical migraine, other kinds of migraine of neurological origin. And so they are usually set apart in a corner because they risk to be considered malingering or psychiatric or whatever. But the patients are really devastated, and the observer doesn't believe them for the most part. But when you have a doubt, please try to treat these patients, because you will get wonderful results. We have done 15 cases with 1 bilateral and 7 cases treated, because we started quite recently with the procedure that I'm going to illustrate. I have never observed a pure median pain. That's why I didn't do any C3 treatment. The median syndrome is coming only from the median part of C3. So usually we treat those patients with the C2, which comes in the one of the half or the 2 halves in one case. Well, anatomy is clear. I don't want to bother you with anatomy. Just to remind you that the core of this treatment is not the same of people cutting the nerve distally or putting electrodes. We have developed a very particular way of treating these patients in the ganglion and putting hot water and some alcohol, but mainly hot water. The cause, entrapment neuropathy, I've seen some tendinous insertions, but I personally do not believe in entrapment neuropathy. I just can tell you that I don't know where this syndrome comes from, but the nerves are that coming from C2. Then the approach can be very simple. There is no need to do any laminectomy, not to destroy any muscle. You can work through the muscle, as you can see. The diagnosis is typical history, evoked pain at the exit of the greater occipital nerve. And then if you want, you can try an anesthetic block and you may have a positive effect. In that case, you may present to the patient, may introduce the possibility to treat these cases. As you will see, they are not invasive. It is just a cut in the midline, but you don't destroy any bone or any muscle. The pain therapist, as I told you, works more on the distal part, and the surgeon, what we do more in the ganglion, in the more proximal part. The treatment options are known. Just I want to talk about a little bit the neurostimulation. I've seen many cases by the antalgic therapist, anesthesiologist, but they never convinced me very much. We have scattered cases with fair results, but they recur, and on the long distance, on the long run, the patients are not happy. Well, again, I don't want to talk about anatomy. I will show you just the pictures. So the place where you have to go is to the ganglion of C2. There is no need of making any distraction. You can just work and preserve the muscle. As you see, it is quite easy. You have to pay a little bit attention. Then this is the picture. The patient is placed, you see, with the head on the right side, and you go on the ganglion. The ganglion is not clear to see, is not fairly visible, because it is covered by a venous plexus, which can be very annoying. Of course, is an annoying bleeding. It is not a dangerous bleeding. Just you must have patience and coagulate and nothing else until you have reached the ganglion. If you coagulate a little bit too much, don't worry, because also the treatment with hot water respects more or less the same principles. As you can see, the bleeding is quite abundant. The channels are large, but you must not lose your good temper. Use flow seal, which is excellent with the venous because it is able to fill all the small holes. And then you inject hot water into the occipital nerve just near the ganglia. Then, if we want, we can use also alcohol. But when we use alcohol, always with a nerve cutter of Meyer, with which we cut the grafts, we put it around the ganglion because we fear that some alcohol goes into the dural sac. So we try to encircle the ganglion with this device and injecting alcohol together with the hot water. The result is excellent, is really fantastic. The patient feels no more pain. And I have only a couple of patients now with some dysesthesias because they feel something like a small, very small regional syndrome because of the destruction of the C2. But anyway, you don't cut the ganglion, and time may help you because they can recover without developing a causalgia or a complex regional syndrome. This is a bilateral case. You see the ganglion. This is very clear. You don't need to make any, as I told you, any cut of the muscle and removal of the bones. Burning in the skin was present. I treated with gabapentin, but they are not so annoying. The patient are so happy that they don't have any more symptoms, that they are able to stand also these small small disturbances of the skin and small neuropathic dysesthesia. So thank you very much for your attention.
Thank you, Stefano. Attractive.
Stefano, may I ask you a quick question?
Yes.
In terms of blocking the occipital nerve, is there a role for a Botox injection in that scenario?
Is one of the treatment that mainly neurologists advise. I had no experience in terms of healing of these patients. I've seen many patients with Botox, but I think that we have to go to the, like Sendou and Caravel taught us, we have to go as more proximal as we can. In this area, we go proximal without making any damage. And I think it is very quick. The only problem, don't get impressed by the venous bleeding. It is just a matter of some minutes and using of Flozil. If you like Baxter, you use Flozil and you can dominate perfectly this bleeding. The result will pay you of not having attempted any conservative measure like Botox, like other treatment that usually the antalgic therapists try first. I go now straight forward to this procedure because it is quite quick, and the cut in your neck is about 4 or 5 centimeters. The patient can go home the day after the treatment, and it is really very satisfactory.
And if you were to give advice to our young neurosurgeons on the panel as to how to quickly and accurately diagnose this condition, what would be your statement, bottom line?
Of course, it is a matter of excluding all the other important causes of headache, of course, because you must not miss a diagnosis which is more important. Then in the big family of the posterior muscular headache of the middle age, you just have to think of this possibility. We usually attain this diagnosis as a last attempt. Usually the patient have tried everything, but if they have this doubt, they can do an anesthetic block of the greater occipital nerve, and then if it works, it could be a good diagnosis.
Great. I think that thank you.
We should move on. We have thank you, Stefano. Thank you, Mahmoud. We should move on for our next speaker, Fernando Gaddis from Brazil, from Rio de Janeiro, head of Department of Peripheral Neurosurgery in Brazil. So Fernando is doing a lot of work in peripheral neurosurgery in whole aspects, especially in tumors. He's author among us with our new book published by Springer about management and diagnosis and management of peripheral nerve sheath tumors, which is going to be published within next few days. And my pleasure to invite him to give a lecture on discogenic sciatica.
Thank you. Thank you very much, Lucas. Are you listening to me?
Yes.
Okay.
Okay.
Okay. Thank you very much, Professor Elo Ahabi, my friend Lucas Razulich, and Professor Koresh for the opportunity. And Jeff gave us a very nice speech. There is no conflict of interest. I heard a lot about clinical examination, and I fully agree with everything that was said. And I must tell you, my friends from Central Africa, that in Brazil, sometimes we are not very far from the problems you have. So this is a paper we have published last year, and pointing out the importance of the clinical examination and also of imaging. Sciatica presents, as all of you know, as a lumbar pain that radiates into buttock, posterior thigh, anterior lateral leg, occasionally as far as distal to the foot. Most of the sciaticas are commonly related to herniated disc compression. I beg your pardon? Are you listening?
Yeah.
Yes.
Okay. Most of these problems are related with herniated disc compressing nerve roots or other degenerative lumbosacral diseases. But there is a small group of patients that the diagnosis is what we call non-discogenic sciatica. And it's very important that a patient with a persistent sciatica, normal or mildly altered lumbar imaging, that we must think in other etiologies. We must suspect that other things may be causing this terrible pain. There are many problems related with non-discogenic sciatica. I put here some of them: traumatic, inflammatory, tumoral, vascular, gynecological origins, and the so-called piriform syndrome that we could discuss here 3 or 4 days about this problem. Concerning neoplastic etiology, the most common tumors are schwannomas, neurofibromas, and malignant tumors. And also metastases, extradural hemangioma compressing the root, many other causes. I call attention of all of you because I have seen one case of this problem here, extrauterine endometriosis. It's called cyclical sciatica. The pain onset is typical sciatica. A few days before menstruation, and it increases gradually and then subsides after menstruation ends. Bob Spinner group has some beautiful papers about this. There is a perineural or superineural spread of this this kind of tissue all along the lumbosacral plexus and also in peripheral nerves. We have seen only one case. Our clinical material, this is a retrospective study. All patients were female patients, and we have seen 2 more cases after the publishing of the paper. And the mean age, you see, this is young people, most of them. And these patients were referred to us from clinical oncology, neurology, pain clinic, and orthopedics. All patients presented with sciatica that you could not tell this is from a discus hernia, what it is. It's sciatica, infragluteal pain. And if you examine the patient and make deep palpation of the infragluteal region, this exacerbated the pain. Also, a positive tinal sign in the distribution of the sciatic nerve. And in all our patients, there was not a palpable mass, except one of the last cases. But all the others, we could not palpate any mass. Motor deficit, only 1 case. So the neurological examination was normal. We've heard some time ago, Dr. Spinner and Dr. Zager telling us that in peripheral nerve tumors, most of the time, the patient has sometimes pain, some sensitive alteration, but most of the time, the strength is maintained. The reflexes are okay. So in these cases here, non-discogenic sciatica, the neurological examination is basically normal, except by the pain and the kind of pain. If you find, and as we will see, a motor deficit, this is generally linked to a more aggressive lesion. Electroneuromyography, muscle denervation in only 1 case, and this was a malignant tumor, and mild radiculopathy in just 1 case. So you see that neurofunctional exams are pretty normal. Imaging, we found 7 cases, we have 2 more, with tumor and extrauterine endometriosis in 1 case. I will just go very quickly in some examples. So this is case 3. This patient had the right sciatica. She was seen in an outside hospital, and an MRI showed some discus problem, but not big problem. Nevertheless, this patient was operated. You can see here some screws. They have done an arthrodesis of the patient, of the lumbar spine, because of the discus problem. And of course, the patient didn't get better. So this patient was referred to our unit, and at examination, the neurological examination was normal, basically normal. The problem was pain, really terrible pain. So we made the examination, and it made deep infragluteal palpation, and the pain increases very much. So we asked MRI of the gluteal region, and there was a tumor. This was, as a matter of fact, a low-grade sarcoma lesion. Here's another patient, young patient, 7-month history of left sciatica. Same story. She could not sit. Many of these patients, they cannot sit very well because the pain increases so much. Showed the tumor here. It was a schwannoma. This is the oldest patient of our series, left sciatica for 1 year. And this lady could not sit. She should have to, even lying down was pretty much difficult for her. And again, gluteal region MRI showed this lesion. It was a myxoma. One of the latest cases, it's not in our series, was this patient, 52-year-old, left-sided sciatica. MRI showed a tumor, a strange tumor. But the only thing wrong was pain. So the tumor was exposed. Neurological examination was basically normal. The tumor was taken out, and the result was a hybrid tumor. Non-discogenic sciatica is uncommon. It's not very common to see. Symptoms are very similar of frequent cause of sciatica. most of the literature are case reports, and they state that palpable massa and sciatica pain are most frequent. Paresthesia you can find, tinel sign you can find, and sometimes weakness. In our cases, we didn't have any palpable lump, just one of the latest cases. All the others, we could not palpate any lump because the tumors were very deep. Pain was really severe, and only one patient had weakness, was a malignant tumor. So one message for all of us who live in countries that we must try to correlate the images we have with the clinical examination, because we cannot ask MRIs all the time, they are very expensive, is that not to rely only on MRI findings in lumbar spine alone, because this may obscure the correct diagnosis. In other words, if the patient has a sciatica, a very strong sciatica, but the neurological examination is basically normal, the strength is okay, no reflex, the reflex are okay, and MRI, you ask for MRI, and the findings in the lumbar spine do not correlate with such pain syndrome, please think another possibility. So we designed this kind of algorithm. I cannot go through it because we have no time, but we designed this algorithm, it's in the paper, trying to, guide the way we think. Probably it's not the best, but it's the way we think. So the conclusion is that non-discogenic sciatica is often misdiagnosed as discogenic, even when lumbosacral MRI reveals findings that inadequately explain a patient's signs and symptoms. So when a patient comes to you with sciatica, with pain while sitting, a positive stenal sign in the trajectory of the sciatic nerve, marked tenderness to deep infragluteal palpation, this is clinical examination, and findings on lumbosacral MRI are inadequate to explain the patient's symptoms and signs, the patient should have a pelvic gluteal MRI, even when no palpable mass is evident. I would like to invite you to the 5th theoretical course on peripheral nerve and brachial plexus surgery. We had to postpone this 2 times. Things here in Brazil are not okay, as you may hear, as you may find in the newspapers, in the news, in the media. But anyway, thanks to the strong support of Wfns and Professor Lucas Razulich, we are prepared to have this course on November 17 to 19 next year. I hope we will be able to do it, and I hope to have all of you in Rio. Thank you very much.
Thank you very much. Thank you, Fernando, for enabling the young neurosurgeons to start thinking outside the box. I think this was a very good example of how one should think outside the box and not continue pursuing the idea that this is a disc prolapse, and sometimes in our settings the patient ends up having a discectomy just because there is a small disc bulge there. So thank you for illustrating that there are other causes that can cause this sciatica, and I believe that the young neurosurgeons on this panel and others as well have learned quite a bit. I think that takes us nicely into our next discussion by Natalia.
May I have a question? May I make a question to Fernando?
Yes, please.
Fernando,
yes.
How are you?
How are you, Stefan?
Fine. What do you think about the phantomatic piriformis syndrome?
I know you are my friend. I knew you would ask me something like that. I knew.
No, because I'm intimately convinced that it doesn't exist. But
I fully agree with you. But 2 of these patients were thought to have this syndrome, and they had injections. Okay, and one of was a patient with a big tumor on the buttock, Okay. I have never operated this syndrome, never. But I must tell you that I have seen a professor of my university, a young guy, very strong, that came up with the sciatic pain. The examination was okay. Really, when you made the full compression of the infragluteal region, the guy said, "Oh, please stop, it's a lot of pain." And he was a guy that would walk on bicycles. He could not sit anymore on the bicycle. So the imaging showed a difference between the piriformis muscle from one side to the other. And I discussed it with the people from MRI. What can you tell me? Oh, it's different. It's larger. Maybe it's compressing the nerve. Okay. So we sent this professor, young professor, to the pain clinic, and they solved the problem. So I have never operated a piriform syndrome. I don't know if one of the colleagues could say something about. I have never operated this. I have never seen a case that said, well, you should go there and cut the piriform and liberate the nerve. I haven't done that yet, and I don't think I will. I don't know. I'm getting old.
Yes, but because many diagnoses are based upon the difference of size.
Yeah.
But in every place of our body, one side may be
different from the other.
Just if you cut your face and you put together the reverse,
it's
you have
different.
two different people.
I agree with you. I don't know.
I think that without trauma, without isotope injection, and so on, I think it doesn't exist. But of course, it is a personal idea. I'd like to know other people more. What Lucas says about, or Bob Spinner also.
Stefano, we discussed this many times. I'm completely sharing your opinion. I also never operated one, the clear so-called piriformis syndrome. I don't know how to tell it, but to see something which I can say this is a piriformis syndrome, exactly. I saw many situations which some other colleagues, let's say, pronounced that this is a piriformis syndrome, but it was not, let's say, for me clear why this is pushing to be some kind of syndrome.
I would agree with the speakers. I'm not a believer. I was sitting next to an esteemed colleague from Italy, and we were listening to somebody talk about their 150 cases. And the person writes me a note and he says, "Am I missing something?" And I said, "No." I said, "I think the person speaking is missing something." And for me, I wrote a paper saying that it didn't exist, that the only thing happened after surgery was now the patient had a pain in the butt from the scar. So I don't believe it, except if there's trauma. But many of the patients that I see end up having a small tumor or ending up having some other reason besides the piriformis muscle. So I'm not a believer either.
Thank you.
Are there any other comments?
Fernando, please, can you stop sharing your screen?
Yeah. Should I keep your screen for that?
Okay, if we have no other comments, I think we can allow Natalia Demisova to give us a talk on iatrogenic peripheral nerve injuries and the situation in Russia. Natalia, are you able to take over? Is Natalia able to?
Natalia, please unmute yourself.
Can you hear me now?
Yes, okay, now it's okay.
Okay, so good morning or good afternoon to everybody. First of all, thank you very much for the opportunity to participate in this interesting webinar. First of all, I would like to show you where I am. Just a second. So this is a map of Russia, and I work and live here in the city Novosibirsk, and I'm a neurosurgeon in Federal Neurosurgical Center. So today I will talk about iatrogenic peripheral nerve injuries. I think all panelists already have a huge experience of this kind of injuries. So I will talk today about Russian statistics. So up to 10% of all traumatic injuries involve peripheral nerves, and about 60% of patients become disabled. In majority of cases, of course, it is big combined trauma of bones, tendons, and vessels, which are involved together with nerves. Annually, about 4,000 to 7,000 people in Russia need peripheral nerve surgery. And iatrogenic nerve injuries in adults are considered to be from 8 to 16%, and in children up to 20%. So the most frequent reason of this iatrogenic nerve injury is different types of osteosynthesis. Then, of course, nerves can be injured during some other surgeries, like direct injuries. And unfortunately, even small surgeries like biopsy can also cause nerve injuries. Also, reduction of joint dislocation or joint replacement can cause nerve injuries. Pressure or traction because of positioning during anesthesia, especially when patient is under myorelaxants already. Cast or splint, tourniquet, dressings, compressions, and of course, injection of neurotoxic substances into the nerve trunk, and some nerve and brachial plexus injuries after radiation therapy. And also, I would like to mention other medical problems, which I can consider also as iatrogenic, because they also lead to the bad results. And unfortunately, these patients are getting actually already medical aid, but the aid is of bad quality, and that's why it has even more problems than at the beginning. So, for example, incomplete first surgical aid. Very often I can see patients like in 6 or 8 months after trauma, and the surgeon has done just skin suture, and that's all, even no tendon suture. So general surgeons or orthopedic surgeons, and unfortunately neurosurgeons, are often unable to recognize and deal with nerve injury during emergency period. And it's interesting to know, we had some kind of questioning of Russian surgeons working in emergency. Well, they were mostly orthopedics. So it revealed that only 50% of doctors are ready to perform peripheral nerve suture in emergency. So other big problem is lack of qualitative diagnostic tools. Of course, the main diagnostic tool is clinical examination, of course. But a lot of neurologists, they rely on EMG. And as you know, EMG is not really informative in early period after trauma. And of course, EMG is really specially dependent method. And sometimes the results are even misleading. I mean, so EMG doesn't have any sense in some cases. Another medical problem is unreasonably long conservative treatment, especially in cases of anatomical nerve ruptures, obvious nerve ruptures, or brachial plexus avulsion. And wrong surgical tactics. So these are examples which I had seen in my practice. For example, incorrect suture technique, bad matching of nerve ends, or using large size of the thread, and which caused big scarring, and that's all. Suturing nerve and tendon between each other, suturing the distal end of one nerve to the proximal end of another nerve. I have seen this in medial bicipital sulcus, so where medial nerve was sutured to ulnar nerve. Another example is using graft from another important nerve to substitute a gap. I have seen this case when surgeon took a piece of ulnar nerve to substitute a gap in median nerve, which was strange for me. And a big problem in Russia is absence of any specialized rehabilitation after surgery. And in most cases, our poor So what are possible reasons of these medical problems? I believe that the main reason is unfortunately poor knowledge of topographic nerve anatomy by surgeons, including neurosurgeons. Of course, highly variable location of peripheral nerves. Also poor knowledge of peripheral nerve symptoms by neurologists. Lack of qualitative diagnostic tools. For example, in Russia, there is no ultrasound, so it's not recommended in guidelines for as a method of examination of peripheral nerve. And now the situation is changing a little bit. So more and more neurologists started to refer patients to ultrasound, but it's still rare, quite rare. Lack of necessary surgical equipment, especially I'm talking about emergency hospitals. So they don't have microscopes, suture materials, microsurgical instruments, intraoperative nerve stimulation devices, and so on. And lack of rehabilitation specialists and centers. Which, well, possible solutions, they are logic and they are coming from previous list, let's say. So I think that somehow the situation can be changed if we change a little bit our study curriculum for surgical specialties, I mean neurosurgical, orthopedics, and plastic surgeons. So I think the course, there should be some obligatory course of peripheral nerve surgery where these young surgeons can observe surgeries, can see patients, can make clinical examinations of this patient, and so on. So another main point is education of neurologists and rehabilitation specialists. Also, I think state problem is providing minimal necessary equipment for all the emergent surgical hospitals. Also, I think it will be useful to include ultrasound examination of nerves to our national guidelines, and also to include MRI of cervical cord for speed brachial plexus injuries to exclude avulsion as early as it's possible. Here are some examples of heterogeneous injuries. So here you can see the median nerve after actually nerve suturing. So there is only one stitch. And of course, the ends of nerve are not matching at all. And so after 6 months, this patient doesn't have any improvement, which is obvious. Another case is ligature on the ulnar nerve. So probably this surgeon was fighting against bleeding, I believe, and that's why the ulnar nerve was ligated together with ulnar artery. And of course, these cases are very popular. I think all of you have seen this. So radial nerve on the plate on the brachial bone. Here is another case. So this is a man with tumor. Actually, this tumor was benign, solitary fibrous tumor on the hip. And he was operated by a general surgeon. And unfortunately, a surgeon resected this tumor together with sciatic nerve. And on our surgery, we have seen a large gap between the ends. So it was, of course, this patient has really bad prognosis, really bad. And so he's quite young, but already disabled. Well, everybody has scenes, so we are not exclusion. So in our center, we have this iatrogenic injury. So this patient of 17 years old, this girl came to our clinic with pineal gland tumor, and she was operated in classical sitting position. Duration of surgery was only 3 hours, 15 minutes, but right after surgery, we had this kind of complication. So she had bilateral sciatic nerve neuropathy with plegia in both feet and paresthesia and pain. But fortunately, in 7 days, foot paresis almost completely resolved, but some hypostasia in her feet stayed for, I think, for several weeks. So this was the only case, only similar case which we have observed, and actually we have done EMG and MRI, and on MRI we have seen some edema of sciatic nerve, so which confirmed our diagnosis. So thank you very much for your attention.
Thank you, Natalia. Any questions, comments?
Well, just make a question for Natalia. The situation you presented here, is it common in university hospital department or just in your area where you have a lot of many things about that?
Well, our center is like federal center, so it has patients from all over Russia. And unfortunately, there are some regions in Russia which have really bad quality, like in general, medical aid quality. And so, and in some regions, it is better. So I have seen patients from all over regions, and unfortunately, almost everywhere there are some iatrogenic injuries. I mean, it's difficult to find some region which is worse than some which is better.
Okay.
Thank you, Natalia. I think that's a very frank, honest, and description of the problems that I think many of our neurosurgeons will relate to. It's just that they don't get diagnosed and then therefore don't get reported. But I think you've outlined it very well, and I'm sure people will reflect back and say, yes, I think we missed on this one, and we and would relate to that. So thank you. That was a very interesting and a frank and honest description of what goes on sometimes and the causes that can lead to it. Unless there are any other comments, I think we're in a position to move on to our next speaker. That's Praveen Shweta, who's going to talk to us on selective peripheral neurectomies and the experience that they have had. Dr. Praveen Shweta is the head of department and chief neurosurgeon at the Department of Neurosciences in the B&B Hospital, Gwarko, Lalitpur in Nepal. And it would be interesting to hear what the experience is in a setting such as Nepal. Dr. Praveen, are you able to share your screen and give us your talk? Hello.
Okay.
Praveen?
Yeah, can you see my slide?
Yes, yes.
Excuse me.
Praveen, it's okay. We are seeing your slide.
Okay, yeah. So hello everyone. I'm Praveen Shrestha from Kathmandu, Nepal. And before I start my presentation about selective peripheral neurotomy, our early experience, I would like to thank Wfns Global Neurosurgery Committee, Wfns Peripheral Neurosurgery Committee, and Professor Lucas and Professor Eliavi for giving me this opportunity today. Well, very briefly, I'll be talking about this topic, selective peripheral neurotomy, our early experience. Well, I think my slide is not moving. Yeah. Regarding neurosurgery in Nepal, well, we have been doing sub-specialized neurosurgery and general neurosurgery because sub-specialization within neurosurgery is not yet well developed in our place. So many of us have been doing this, both general neurosurgery and specialized neurosurgery. But recently, our young neurosurgeons have started taking up a field of their interest, like spine, vascular, endovascular, neuro-oncology, etc. But for peripheral neurosurgery, so far, nobody has taken up this field as their specialized neurosurgery. But many of us, we have been doing peripheral neurosurgery. Some are doing much more and some are doing less, but most of us are doing. And I have been doing, I think, quite a number of cases in peripheral neurosurgery. That is what I'm going to share with you all today. Well, this is the proportion of peripheral neurosurgery in our experience, about 10% of total neurosurgical caseloads. Almost same spine and brain, about 45% each. This is a list of peripheral neurosurgery that we have been doing in our regular neurosurgical duty. Among these is selective peripheral neurotomy, which I'm going to talk about very briefly. Well, as you all know, this selective peripheral neurotomy is indicated for severe and focal spastic deformity or spastic hypertonia of the limbs. Spastic hypertonia is an upper motor neuron syndrome, which is caused by defect in central nervous system, either brain or spinal cord. And symptoms are motor deficit, spasticity, hyperreflexia, clonus, Babinski signs, etc., resulting in involuntary muscle contraction and finally leading to the significant neurological and functional disability. Well, spastic hypertonia is mainly caused by traumatic brain injury, spinal cord injury, cerebral palsy, stroke, meningoencephalitis, etc. And the main surgical aim is to denervate the peripheral nerve, whichever is involved in this particular muscle hypertonicity or hypertonic muscle. At the same time, the surgical aim is to preserve the residual motor and sensory function of that particular muscle and thus the function of the limb. So the common nerves involved in upper limbs are median nerve, ulnar nerve, and lower limbs nerves are operator nerve, sciatic nerve, and tibial nerve. Well, here are a few illustrative cases. This is a young lady with left hand deformity, as you can see, because of her childhood meningoencephalitis. The hand and the fingers are almost always, spastic like this. She cannot open her fist. There is also deformity on the left foot, but this is not a big problem because this is often not visible. But this is the problem, as you can see, every time in whatever position she is sitting or standing. So we plan for the selective median neurotomy in this particular case, incision and exploration of the underlying tissues. The median nerve and all its major branches have been exposed. And finally, we find out the nerve, which is particularly responsible for that hypertonic muscle, leading to that deformity. We identify the nerve with the help of nerve stimulator. And finally, once it is identified, we open up all the nerve fascicles and we do neurotomy more than 50%. And then finally, we check whether the hypertonicity is corrected or not with the help of, again, nerve stimulation. So this is a post-operative picture after surgery, the same lady. This is the correction of the hand. As you can see, it was like this before surgery. Now it has become like this. This is again the same lady. The hand has become like this. This was the deformed hand. This is the incision site. And this was the deformed hand, which has become like this now. So now she is in a little bit more comfortable position, but definitely her functional recovery is not satisfactory, which we always explain to our patients before surgery. Well, this is a simple device, device that we use during surgery. This is the stimulator. This is the neurophysical monitoring system that we use during surgery. Another case, a young boy with right hand deformity like this. And again, he was operated in the same way. Median nerve neurotomy was done. This was the deformity before surgery, and after surgery, the deformed hand became like this. But again, of course, there is a limitation of functional recovery. This is a small boy with deformity, especially in the wrist joint, in addition to the fingers deformity. Again, the same procedure, same surgery, and the boy recovered to some extent with the correction of the wrist deformity like this. Well, this gentleman had a severe spastic paraparesis because of the spinal cord injury a few years back before coming to our outpatient department. He could hardly stand up. Every time he was almost wheelchair bound. His legs are crossed like this. As you can see, when he tries to stand up, his legs are crossed. He could not stand properly. There is severe flexion deformity of the both knees and also equinus deformity at the ankle joint on the both sides. So in this particular gentleman, he had involvement of obturator nerve, sciatic nerve, and tibial nerve on the both sides. So this is how he presented to our department like this, continuous severe clonus with deformity, flexion deformity in the knees and ankle equinus deformity. So in this case, first we did selective obturator neurotomy on the both sides. This is the obturator nerve here and the branch here. And this is after the surgery. There's no more crushing of the leg, but he still has severe spastic spasm in the knee and ankle joints. So it is still difficult for him to stand and walk with the support. Then in the same person, we did second surgery after a few days, bilateral sciatic nerve neurotomy, which we had planned earlier. This is the sciatic nerve on the both sides. Did the sciatic neurotomy in the same way as we did in other cases. And this is the third surgery in the same patient, tibial neurotomy on the both sides. The extensive exploration of the tibial nerve and its branches. And then we did neurotomy on the both sides in the same way. And this is finally after 3 neurotomies. As you can see, now there's no more crushing of the legs. He's in a better position. He is more comfortable on the right side, but still you can see on the left side, there's still difficulty in stepping properly with his feet. So he's in a better position, but of course he still has some difficulty because of the spastic limbs, but he could walk with the support like this. This is another small boy with bilateral severe clubfoot deformity. As you can see here, this is the front part. This is the knee on the both sides. And he was crawling all the time. He couldn't stand up. He couldn't walk properly, of course. And whenever we tried to make him stand up, his feet become like this. He has to step with the dorsum of the foot. He could never step with the sole of the foot. He was really in a very pitiful situation. And we planned for the bilateral neurotomy as we did in the other cases. As you can see, this on the both sides, surgery was done into different steps. This is after the first surgery on the left leg. He could step with in a more comfortable way. As you can see here, you can see these scar marks all the time because he was stepping on the dorsum of the foot. So he had multiple injuries and is a scar because of the stepping on the dorsum of the foot. He still has difficulty on this side because it was not yet operated. This is after a few weeks of surgery on the both sides. You can see he could now step in a more comfortable way, but he still has difficulty in standing and walking independently. He couldn't do that after surgery also, and immediately after surgery. This is a scar mark after surgery, after a few weeks of the surgery. This is the boy here, and this is the same boy after a few months of the bilateral tibial neurotomy. Now he has become like this. At least he could stand up in a better way. He could walk more comfortably. Otherwise, he was never able to stand up and walk. But still, you can see he has a spastic adductor adductor muscles spasticity. So there is, still difficulty in walking. So in this small boy, we had planned for obturator neurotomy as well, but somehow we could not do that in this case. Well, in such cases of spastic deformity or hypertonia, only selective peripheral neurotomy is not sufficient. In addition to this neurosurgical procedure, the patient also needs to go long-term rehabilitation and also some orthopedic procedures like bony correction or tendon transfer or tendon lengthening. With all these multidisciplinary approaches, finally the outcome becomes better. So in conclusion, peripheral nerve surgery is one of the major branches of neurosurgery. It's a sub-specialization within neurosurgery, as you all have mentioned, but it is often ignored. It is not yet well developed in the places like ours, probably because of the less manpower and because of less developed sub-specialization within neurosurgery. PNS is a very simple surgical procedure. It's not a high-tech surgery. It's a cost-effective, not expensive, but it is we need to further improve, our knowledge, skill, and outcome about peripheral nerve surgery, and we need a bigger experience. Thank you. Thank you very much.
Thank you, Praveen. Any questions, comments? My comment should be regarding importance of doing these neurotomies, since they can be really helpful to the patient, especially when you have a clear indication and depending how either you are doing hyperselective or selective neurotomies, this is something which is still part of peripheral nerve surgery, although it can be treated like a functional neurosurgery. But then the mandatory is a knowledge of the anatomy and correlation with functional lesions.
Yes, it is especially difficult in case of upper limbs when the hands and fingers are involved, because as I have told you, there can be some cosmetic or anatomical correction can be made with this surgery, but still the patient becomes functionally disabled. Still he or she cannot use hands and fingers properly even after the surgery. So in such cases, there is a limitation of this surgery, but of course, sometimes only even cosmetic correction can be of big help to the patient. This is what we explain to the patient before surgery. Yeah, it's kind of surgery.
Okay, so we should move to our last, but not least, speaker for today, our dear friend Ketan Desai, who is a prominent neurosurgeon from India doing peripheral neurosurgery, also member of the Wfns Committee for Peripheral Neurosurgery, with a vast expanded experience in peripheral neurosurgery. So Ketan, please, can you give us your experience in
Thank you very much, Lucas.
Peripheral nerve problems.
Thank you, Lucas. Can you see my screen?
Yes.
Thank you. Thank you, WFNS Global Committee, for giving me this opportunity to talk on my experience managing peripheral nerve problems. And one of them, which I'm going to talk today, is on heterogenic nerve problems, which we have managed and treated over the last 20 years. In India, in reality, peripheral nerve problems are in a big number, and they are treated by a wide range of specialists, including physio and occupational therapists. So far as the neurosurgeons are concerned, they are very limited numbers. The reasons are manifold. One of the principal reasons is lack of training and exposure in their department, where very few centers in our country are genuinely doing peripheral nerve surgery related work. So their exposure and their trainings are limited. Also, they are too busy in their general neurosurgical work So peripheral nerve work is relegated in the side. Also, there is a general perception that physiotherapy is the best treatment option for management of peripheral nerve problem. So combine all this, to be very honest, very few neurosurgeons are involved actively in management of peripheral nerve problems. Although in the recent times, the situation is improving, but still in the major society meetings, the peripheral nerve topics are not very enthusiastically discussed and debated. The word heterogenic means unfavorable response to medical and surgical treatment. And with respect to peripheral nerve, they are following surgery or some procedures like injections, block, central line placement, and as Dr. Natalia mentioned, position-related palsies are also quite known. But there are some potential problems managing heterogenic problems, now related problems. It's a development of a sudden new problem when one problem is already existing and new problem creeps up. So it's very difficult both for the patient and the surgeon to tackle this problem. Generally more common with surgeons, but anesthetists and intensive care specialists are also encountering this type of problem with various procedures which they do. And the main important thing is litigation problem, medical legal issues related to this. And literature reviews suggest anywhere between 8 to 10%. So litigation is a major issue, and that is a hindrance sometime in referring patients by the treating doctor to a specialist managing nerve problems. The other issues are late referrals, too much emphasis on physiotherapy, and sometimes there is quite often reluctance on part of patients to go for another surgery because he feels that one surgery has already caused some complications and problems. So he's a little bit reluctant to go for another surgery for treatment of the nerve injury. The literature data is very variable of the incidence of iatrogenic problems, anywhere ranging from 1.5 to 15%. The drawbacks are because the true incidence is not reported in literature, and the assessment is very subjective with respect to physician and patient as well. So ideal thing would be avoidance of complication. Always prevention is better than cure. And related to the timing, I think if the deterioration of the injury is very severe, early surgery is definitely recommended. And the investigation of choice in our experience was EMG and MRI. And these are the few examples of MRI investigation helping us know what the problem is. This is a case of a brachial plexus tumor operated, but while excising the tumor, the nerve was also sacrificed. And you can see here the MRI neurography showing abrupt termination of the roots on the MRI. So this denotes that there is a sacrifice of the brachial plexus element. Another case of a median nerve injury following repeated IV punctures in the veins in the region of elbow, and the median nerve shows signal changes on MRI. Another case of a tibial nerve injury following a calf reduction surgery, which was performed, and as you can see here, there is a gap between the two ends of the nerve with a neuromatous formation. So in last 20 years, since we started operating and dealing peripheral nerve problems, we have tackled about 681 patients with iatrogenic peripheral nerve injuries from the year 2000 till date, and of which 87% patients were surgically treated and 12.8% patients were conserved and non-operated. Of the 87% patients who were surgically treated, the major chunk, 50% patients, were patients with post-intramuscular injection-related palsies. 38% were following surgeries. 10% patients had nerve palsy following various procedures like blocks, nerve blocks, IV injections, central line placements, and a small subset of injury was following position and tourniquet applications. I have not included radiation therapy related injury in my experience, although we have managed a significant part of patients. The non-operated groups were basically comprised of the patient who either refused surgery or we as treating physician refused surgery because they came late or already some surgery was performed or they were unfit for surgery. And 34 patients were observed because their deficit and injury was not very severe. And if you see this table, very interesting table to summarize our experience. In the initial 10 years, the intramuscular injection-related palsy was a major component. But in the last 10 years, that percentage has significantly dropped and post-surgery and the procedure-related problem has increased. So this is our experience in nutshell, showing the various types of problems which we have tackled. Coming to the post-intramuscular injection palsies, mainly sciatic, radial, and axillary nerve were affected in our experience. Basically, it was the wrong site of injection which was given intramuscularly, and we found that the patients who encountered this problem were quite a significant percent, were thin, lean individual. Children were more commonly affected, and the basic reason was that either the injection was injected directly into the nerve or into the surrounding soft tissue like muscles, which bled or caused inflammation because of the oil-based type of injection which was injected. Besides sensory motor deficit, neurogenic pain was a major problem in quite a significant percentage of patients. And the treatment obviously was neurolysis or neuromyxin and grafting based on the intraoperative findings. And this is the second subset of injection-related palsy following block procedures or central line placement. As you can see here, various elements of brachial plexus getting injured following block procedures. And one example is post-central line brachial plexus palsy upper trunk. You can see a large neuroma because of the central line placement, repeated attempts, not properly done, poor technique. And there is a standard of protocol that always when you do block procedure or a central line placement, definitely help of ultrasonography and use of stimulator should be done to reduce the rate of complications. This is another example of a infraclavicular block injection for a lipoma excision in the arm. You can see signal changes on the MRI. Another case of a median nerve injury following repeated IV punctures in the region of elbow, and the nerve was found to be contused at the surgery. Just summarizing our experience is a very busy slide, but just to summarize it, as you can see here, the results were very good, rewarding, except two groups of patients with sciatic nerve injury and lower roots of brachial plexus. Those two groups of patients had not very good result compared to the other nerves which that were tackled. And with relation to the timing of surgery, early surgery, better outcome compared to the surgery performed late with respect to the functional outcome. Another subgroup was heterogenic injury following various surgical procedures and implant. This is one case of a radial nerve injury following external fixator application. Another very commonly noted finding of radial nerve palsy with humerus plating. Another case of a ganglion cyst excision. As you can see here, the sutures were passed through the median nerve during surgery. Very commonly encountered problem of cervical lymph node excision biopsy with spinal accessory nerve palsy, profound wasting of trapezius muscle, acetabular fracture surgery with sciatic nerve palsy, a posterior introosseous nerve palsy with following a radial head excision endoscopically. This patient had a immediate palsy following this endoscopic excision of radial head. Another example of a cement seepage through the bone while nailing the humerus and causing compression on the radial nerve. This is a seeped out cement through the bone. And commonly encounter problem of brachial plexus tumors. And any tumors which are not excised properly can inflict a major neurological insult. And these are the few examples of brachial plexus tumors, excision following which they had brachial plexus palsy. Another case of an ulnar nerve tumor, excision with sacrificing of the ulnar nerve. A very interesting case of a varicose vein treatment where the stripping of the varicose vein was done along with that posterior tibial nerve injury was found to occur. And the summarizing our post-surgery related heterogenic problem, as you can see here, they had a rewarding outcome, but the peroneal nerve component had not a good result, and only 23% patients in our experience after surgery improved functionally. And its timing definitely better early the surgery, better the outcome as would be in all nerve related problems. And finally, very small subset of problems like tunicate palsies. We had 9 patients with tunicate related palsies where multiple nerves were involved in the forearm, and this was basically due to prolonged tunicate application under high pressure resulting in a compartment syndrome and ultimately landing up with multiple nerve-related palsies. And position-related palsies, we had 7 patients, of which 4 had brachial plexus injuries and 3 had peroneal nerve palsy with foot drops. This is the position we find surgeons operating because maximum assistant stands here and they go on pushing the arm up and up. And this arm outstretched arms, if the surgery is prolonged one for long hours, this can definitely cause stretching of the brachial plexus and may result in brachial plexus palsy. In fact, one of our patients woke up with a bilateral brachial plexus palsy of varying severity, and eventually one-sided needed surgery. So to conclude, prevention is always better than cure. Timely and aggressive treatment is definitely mandatory to have a better outcome. And one should definitely keep in mind the medico-legal aspect which is associated with this type of problem.
Thank you. Thank you, Ketan. Any questions, comments?
Hey, can I ask my question?
Yes.
Question is about the post-intramuscular injection injury. What is the timing for surgery and indication for surgery in this case due to urgent surgery after sciatic nerve injury of intramuscular injection? And the second question is about the tourniquet injury. Do you explore the site of tourniquet, the site of injury at the tourniquet level, or all the course of the affected nerve?
So regarding intramuscular injection palsies, the treatment option, it should be, as any nerve injury, we watch for a period of about 3 months and see how it's progressing. If it does not progress well, and if the deficit persists, plus if the pain is a major problem, and if EMG documents that there is evidence of denervation, then generally we advise surgical intervention. So we wait for a period of about 8 to 12 weeks and then take a call regarding surgical management. I forgot, what was your second question, please?
My second question is about the injury due to using of tourniquet due to ischemia.
Yes.
Okay. When you explore these nerves, do you explore at the site to do neurolysis? Do you explore at the site of the tourniquet, or all the tract of the nerve?
Yeah, it's a very,
to do neurolysis.
It's a very difficult call to make, but generally what we have found, we have a very limited experience, to be very honest. We have only 7 cases. But what we have found is that the site of tourniquet is the application is the site where this all nerve gets scarred out and they get tethered to the surrounding soft tissue. So we generally, although the incision length is a big one, as you would have seen in one of the photographs which I had shown, but we generally explore the site of the tourniquet.
Do you recommend using of a heavy dose of steroids at the time of injury to improve the recovery?
To be very honest, we have tried, but we haven't found any significant benefit or advantage using steroids.
Okay, thank you so much.
Thank you.
Are there any other questions from the participants? Great. I think, Lucas, you'll agree that this has been a wonderful expose of not only the treatment modalities, but as Ketan's lecture shows, how these can be avoided from a heterogenic point of view. And I think you've learned a lot during this afternoon, both on, and then obviously Robert's lecture on trying to keep it simple was another illustration of how to approach such injuries. So I think we really have to commend the Wfns Peripheral Neurosurgery Committee for bringing this to our doorstep in Africa, and along with that to other lower middle income countries as well, where this kind of surgery is not done regularly. So I'll leave that to Professor Wahabi to give us, and to you, Lucas, to give us any concluding remarks.
Yes, once again, I would like to thank all. First of all, WFNS Global Neurosurgery Committee for creating this platform for this joint venture with the World Federation of Neurosurgery Society Peripheral Neurosurgery Committee. I would like to thank all panelists who give us lectures. I believe that audience are finding this webinar useful for them and intriguing to start thinking about how to deal with the cases of peripheral neurosurgery. Of course, I'm sure that all of us are more than willing to help in education, all who are interested in peripheral neurosurgery. These fellowships are already ongoing in all reference centers within the World Federation Neurosurgical Committee for peripheral neurosurgery. So I think we should be satisfied. And just to conclude that for something who has nothing, something is a lot. So this is one of the most important reasons for doing peripheral neurosurgery, to help people in improving their quality of life. And it is, and it will be an essential part of neurosurgery. Thank you very much for your attention.
Thank you, Luca. Thank you for all the speakers, and it was a wonderful afternoon. We learned many things about the subspecialty, and I think the goal of the webinar was to bring together many experts all around the world, and we learn about the different cases around the world, the epidemiologic situation, and we found that there are many situations that are still like in Africa. And I think this means that this subject of subspecialty of peripheral neurosurgery is not something that many neurosurgeons are dealing with. So that we bring the attention of all young neurosurgeons that this is one of the most important part of neurosurgery, and this is microsurgery, so they have to learn about it. And I was very happy to learn that there are many opportunities for them all around the world, and your presentation, Luca, gives this information is very important. There is another thing that we can learn, of course, by case, but also by doing some cadaveric works. And this is unfortunately it's not available in Africa, but maybe it will be possible for them to join those centers where it's possible. So thank you very much for all the speakers. We learned lots from them, and I think that the goal of the webinar has been achieved, and the young neurosurgeon will certainly benefit from their webinar. Thank you very much.
Thank you.
Thank you.
Thank you all.
Thank you. Thank you.
Bye-bye.
All right. All the best. Thank you, everyone.
Yes, bye-bye.
Thank you.